Hello, good morning or good evening, good afternoon, everyone. My name's Amy Freeman-Sanderson, and I'm delighted to welcome everyone to our second webinar for 2025. So thank you for those who are joining live. It's great to have you here. And also those of you who might be watching on catch up as well. We appreciate you following up. Today's session is on tracheostomy decannulation, pathways and considerations. And I'd like to acknowledge and thank our sponsors for their support in making these education webinars possible for the audience. So would like to acknowledge them. In terms of also where we are as a global community, I'm in Sydney, and I'd like to acknowledge the traditional custodians of knowledge for the land that I'm on. So I'm on Gadigal land from the Eora Nation, and I pay my respects to the elders, past, present, and emerging, acknowledging them as the traditional custodians of knowledge for this land. Oh, I don't know. Hopefully you can see my screen. There you go. Just a thumbs up from the panelists. Can you see the screen now? Yeah, perfect. Thank you. So sorry about that. So welcome everyone. Please feel free to use the Zoom options available that you have in regards to where you are joining us from today. So feel free to pop that as a hello in the chat. So today we're going to cover off a few aims, so some big ambitions in the next hour, but we're really going to talk about different decannulation pathways, and we're going to touch on adults and pediatrics. So talk about what's similar, what might be different, parts of success and specific considerations. Talking about the list of essential prerequisites for decannulation, the role of different team members, and really importantly, hearing the family and patient voice around the importance of having the families as key team members and considering our how we manage. Also looking at how we're maximising success and safety along the pathway of decannulation. So I would like to hand over to my co-moderator, President of the GTC, Dr. Vinciya Pandian.
Thank you, Amy. So delighted to see all of you here today. We have a wonderful group of panelists here who are going to be sharing their experiences and the work they've done in the decannulation space. And decannulation was actually one of my first projects that I started in tracheostomy care, apart from putting a team together. So it's very dear and near to my heart in terms of what happened at my institution and how we had to address that issue in a very strategic, standardized manner, and really trying to get the buy-in from all the stakeholders to create a change in practice. So I'm really looking forward to hearing from all our panelists. So first we have Dr. Reshma Amin, who's the Director of Long-Term Ventilation and Sleep Medicine at Sick Kids in Toronto. She's also a professor of pediatrics at the University of Toronto and was named the 2025 Researcher of the Year by Muscular Dystrophy in Canada. Our second speaker or panelist is Dr. Gonzalo Hernandez. He's the Chief of Weaning Unit at Toledo Hospital, and he's got long-standing experience in weaning from mechanical ventilation and caring for tracheostomy patients. I was definitely I learned a lot from one of his unique project that he did, where he did a unique approach of decannulating, or not decannulating, really weaning patients from tracheostomy. So I'm really looking forward to hearing more from him. And he's done work on preventing extubation failure and predicting risks for failing weaning as well. Our third panelist is Dr. Laura Estanbullion, who is an assistant professor of nursing at Toronto Metropolitan University and a clinician scientist at the Provincial Center for Excellence in Prolonged Ventilation Weaning in Ontario. And then we have Dr. Matt Maksimowski, sorry if I pronounced your name incorrectly, who is a pediatric ENT surgeon in Milwaukee and an expert in tracheal and laryngeal pathology. He completed advanced training at Cincinnati Children's Hospital and authored the best practice guideline on tracheocutaneous fistulas. We also have Stacy Venas, who is a social worker with over 20 years of experience, currently serving in a hospital's patient experience department. She's also a caregiver, mother, and the author of The Man with the Sad Face, a children's book inspired by her personal story. And last but not least, we have Erin Ginelli, who is a clinical lead speech and language therapist for critical care and neurosciences at the Royal Free Hospital in London. I know I can take a lot more time to share all the amazing work our panelists have done, but I do want to give them the opportunity to showcase their work. So with that, I'll hand it over back to Amy.
Thanks, Vinciya. So let's move into our panel discussion. We're going to be going through these topics. So we've got some talking points and flags. So please follow along with the discussion. We love hearing your comments and questions. So you have the Q&A option in your Zoom. Please post any questions that you have there. We'll aim to address them as we go along within these topics. And we've also reserved a bit of time at the end. So please feel free to add in any thoughts and comments there. So also just in regards to Erin, unfortunately, she's just joining us now, but I wanted to move ahead and talk to some of her work. So with that, so topic 1, what does decannulation actually mean? So as Erin has highlighted to us, there's so much different terminology that's used with the process of decannulation, the decannulation pathway. So here's just a couple that may come up or are regularly used in your clinical discussions, or you've heard them as a family member or patient. So we've got decannulation, tracheostomy weaning, capping, corking, spigoting, capstoma button, spigot, speaking valve, one-way valve, passing valve. Many terms are used in the process of decannulation, and we really wanted to sort of highlight and me to start the conversation with the panel about why does terminology matter, and what is it that we need to do in terms of ensuring we're speaking the same language. So defining what we mean by the specific terms we use, we're enhancing communication and really looking at increasing the safety and efficiency of what we're doing, and also addressing any unknown terms, which can really drive anxiety and uncertainty across team members. So for example, your institution might use the term decannulation as the actual physical removal of the tube, and some others might start that the process of decannulation talking about weaning, and you referred to that right back in the intro as well, Vinciya, in terms of that connection of the process towards decannulation. Decannulation, really do come together. So I just wanted to throw it to the audience in terms of terminology and the importance of using and explaining these terms. Any thoughts about that from the panel in terms of where you might needed to do that, or to clarify what you mean? So maybe Laura, just in terms of your experiences, can I call on you first in regards to the importance of terminology and how does that drive collaboration across the team?
Yeah, absolutely. As you mentioned, we do use, even amongst ourselves, different terms. And where I work, we have patients who come from other institutions as well. And so they move across different hospitals and different care teams. And so they themselves will hear different terms. And you can imagine how confusing it would be if a family member or a patient hears that they're going to be weaned one day and then decannulated the next day. And we actually mean the same thing. And so you're absolutely right in terms of it could be anxiety provoking, but sometimes it can fracture the trust, and really ultimately impacts the patient's ability to really understand what's happening next in their care.
Yeah, definitely. That's a good point in terms of that sort of trust and the steps that what we're doing can drive that certainty of management. What about in terms of pediatrics? I wanted to ask, Reshma and Matt, just in regards to your experience with terminology. Do you see these different terms being used and the importance of us as health professionals and team members needing to clarify?
Yeah, thanks for the question, Amy. I think the importance, especially in the pediatric realm, is just laying out the journey, and that often this is not a process that we're initiating that's going to happen tomorrow. And I think it's really important to be very clear and transparent about what are sort of the key milestones and goalposts that we need to achieve before we can go to the next step. Just because as soon as you mention to a family, your child, we're thinking about decannulation, they want that to have happened yesterday. So I think clear communication in terms of sort of what to expect and the sequence of events and the milestones and the trajectory is very important.
Yeah, I couldn't agree any more with what she said. And I think that, that importance of terminology really goes both ways. In the sense that there are children or families who will hear the phrase decannulation when you mean weaning from whether that's a ventilator or some other form of support, or getting towards a point where they're able to breathe on their own. And for some of them, that idea of the trach coming out is so exciting. Removing that is such a wonderful thing, and they look forward to it. And there's some that is the most terrifying thing that they have to deal with, because they've relied on that as a lifeline for their child's airway for so long. For some of them, that the step of taking it out can seem very scary to them. And so understanding and making sure we're all using the same terms, speaking the same language is immeasurably important there.
Yeah, thanks for that. I could see a lot of nods, Stacey, from you as well, just sort of nodding through some of those key points that are mentioned. Really, and I like sort of what you highlighted there, Reshma and Matt, but that dual communication and two-way communication. Yeah. So, I mean, in terms of that, then we've started talking about these journeys and pathways. Let's move into them. So, what are the typical pathways towards decannulation in pediatrics? And I'll hand over to you, Reshma.
Next slide. So I just want to cover, very briefly, what do we have in the literature that's published in terms of decannulation clinical practice guidelines. So from the American Academy of Otolaryngology, they published a guideline back in 2013, and they've identified some key steps here. So one of which is that the child should not be requiring ventilatory support for at least a period of 3 months prior to decannulation. They really should be free from aspiration events. They need to have had a flexible laryngoscopy to document a patent airway with at least one mobile vocal cord. And then importantly, children who are more than 2 years of age should have their tracheostomy tube capped all day for several weeks. And notably, I just want to draw attention to this age of more than 2, because these guidelines very clearly stated that they don't feel that children who are less than 2 can tolerate being capped, just because the caliber and size of the trach tube itself is quite close to the actual diameter of their actual airway. And similarly, often we will be downsizing tracheostomy tubes for older children. And similarly, we have challenges with downsizing trach tubes for children who are less than 2, sometimes because there just is no smaller tube to downsize to, but also it's important for us to think about sort of these small tubes that are really at risk for mucus plugging. And then once you achieve daytime capping, if you are more than 2, then really a next key step is prior to decannulation, the guidelines advocate for either a capped sleep study, a capped exercise test, or a nighttime trial while in hospital and being observed directly. So from the American Thoracic Society, these guidelines were published in 2000. They're a bit more general, less sort of specific per se, but the recommended protocols really involve, sequential downsizing of the tube with partial or complete capping over time. And then they advocate for a one-stage decannulation procedure where you have sort of endoscopic examination of the airway with tube removal during evaluation. And happy to share that there's going to be a pediatric chronic trach clinical practice guideline published by the ATS. It should be out, hopefully, fingers crossed, in the summer, and 2 of the 6 PICOs actually speak to decannulation. Next slide. And so just in terms of the American Academy of Sleep Medicine, when they have their statement looking at practice parameters for respiratory indications for PSGs, they have one comment in there that states that children treated with tracheostomy tubes for sleep-related breathing disorders will benefit from a sleep study as part of that evaluation prior to decannulation. Next slide. And so with all of these different clinical practice guidelines that really are advocating quite different things, some similarities, some differences, the question is really, what are clinicians actually doing? And so our group conducted a systematic review, next slide, in which we reviewed the literature, and there was a total of 24 studies that were included, that included just about 1,400 children. And so for the tracheostomy tube indications for this cohort of children, for about 35% of them, upper airway obstruction was defined as being that of a well-defined anatomic site is the reason for the tracheostomy tube. In about 12%, they did not have a well-defined anatomical obstruction or had an underlying medical condition such as, for cerebral palsy, and then 53%, so the majority required the tracheostomy really for access to the lower airway for long-term ventilation or pulmonary toileting. And if I can shift your attention to the right side of the slide, if we go back to the other slide, you can see here that these percentages really reflect these different diagnostic items or tools that were used for decannulations and the frequency with which they were used in the different protocols. So ranging from 96% of decannulation attempts, those patients all underwent a bronchoscopy prior to that attempt, all the way down to, at the bottom, you can see only 8% of those patients underwent the use of a fenestrated tracheostomy. So quite variable in terms of the different tools that are used here. And so this slide is really showing just the flow chart outlining the articles that were retrieved. So we identified just about 1,300 articles, of which 736 were reviewed after we reviewed all the duplicates. We were then able to identify 40 articles for full review, and then ultimately 24 articles were eligible for inclusion. Next slide. And so in terms of what we found that in fact 91% of those children underwent decannulation and 72% of them were successful. Interestingly, if we look at all of the patients, there was a pre-decannulation bronchoscopy in all of the patients that failed, but there was only a pre-decannulation sleep study in 24% of those who failed. And interestingly, there's quite variable duration of what a capping trial entails, and that can range from sort of 12 to 24 hours. Next slide. And so if we look at this data in a slightly different way, so what you're seeing on your screen now are the decannulation failure rates without PSG's pre-decannulation, and we sort of looked at each of the different studies, and overall there was a total failure rate of about 15% for children to fail decannulation if they didn't have a sleep study, which is in contrast to the next slide, where you can see the decannulation failure rate with the PSG is much lower, so only about 4.2%, highlighting really, next slide, the importance of some type of gas exchange measure as an important parameter to be looking at in addition to airway evaluations prior to decannulation. So I think a lot of conversation will come up about that and sort of the correct approach for decannulation. And just before we jump to the next topic, I just want to highlight a particularly sort of important aspect of decannulation in pediatric patients, and that really is this transition from invasive to non-invasive ventilation. And what you're going to see on this slide here is the approach that we take at my home institution at Sick Kids in Toronto, Canada. And so here we have patients who we get referred to our joint RESP ENT clinic. And the patients that were being considered along this sort of pathway are those who are medically stable, they're off daytime ventilation, and we think they're good candidates for nocturnal ventilation. They then will progress to daytime capping of the tracheostomy tube. We will then do an air trial in which we will work with our respiratory therapist to fit the patient with a bilevel mask. We'll also turn on the air to see how the patient tolerates that. If that all is progressing nicely, then we'll move to initiating bilevel ventilation at night in the sleep laboratory with that tracheostomy tube capped. And if that also goes well, then we initiate a period of 24-hour capping, and the patient begins to use bilevel non-invasive ventilation during sleep at home. And then we sort of follow closely for a period of about 3 months. And at the 1 month mark, our respiratory therapist will reach out to the patient to review how things are going with the bilevel ventilation and get a ventilator download. And then we bring the patient back to clinic at 3 months if everything is going well. During that visit, we meticulously check the download to make sure there's not a single day of misuse. And we also want to ensure the patients had to manage through an intercurrent illness without having to remove the cap for direct tracheostomy tube suctioning. If they get green check marks at that point, then we lean into our ENT colleagues who will do a full airway evaluation in the OR if there's not one that's been done already, and they'll plan to admit the patient for decannulation. And then things don't stop there. We have to follow the patient up afterwards as well, which is sort of the part that we sometimes forget, because things can go wrong, and they do go wrong. And if we don't plan for them, they will go wrong. And so we typically will have a follow-up. Our RT will call the family just to check in and see how things are going. What's the tolerance like? What's the leak coming from the stoma, and how are they managing that? And are the saturation stable sort of overnight despite that? And then we see the patient jointly in clinic about a month later with ENT as well, just to ensure the stoma is completely closed, and we'll also just ensure that the ventilation is going along well. And then if all of that's progressing nicely, then we'll reevaluate the patient, typically in the sleep lab, now that the stoma is completely closed, to see if we need to adjust the settings further. So perhaps I will leave it at that and then open up to the fellow panelists to sort of comment.
Thanks, Reshma. In terms of, I mean, as you highlighted, quite a sort of a journey and lots of considerations, particularly with that transition and considering ongoing vent needs as well. We're going to pick up on some of the aspects that you mentioned a little later, but just now, Matt, is there anything that you wanted to add in just in regards to those additional points around that involvement of ENT?
No, I think that, Dr. Amin has really emphasized that, it's not us, it's not, respiratory therapy, it's not pulmonology, it's not a one person or a one division or one side of the spectrum that kind of drives things. It really is kind of looking at different things. We all have different concerns, we all have different things that we see a lot of, and anytime you can get a coordinated visit, you're going to get better collaboration, better talking between them, and so that's always going to be a good option if it's available to you, and if not, just keeping those lines of communication open, or engaging those other specialists who may have seen the patient, who may have some different opinions, different evaluation, different way to look at things.
Yeah, thank you. Yeah, thank you so much, Dr. Amin and Makimoski. What we will do now is sort of continue on the topic of decannulation, but I want to switch populations and really sort of start that conversation in regards to looking now at the adult populations. Are pathways different, and what sort of variations in practice are there? So I'd like to hand over to Dr. Hernandez-Martinez to lead us in that discussion around decannulation in the adult population.
Okay, thank you. So clearly, after listening to the previous lecture, the pathways to decannulate tracheostomy patients mainly depend on the kind of patient and the indication of the tracheostomy. I just want to give some points on epidemiology of tracheostomies, because in my opinion, these points will change pathways and management of tracheostomy patients in the future. So the main points are there is growing evidence for early tracheostomies, and these include from about last 10 years a switch to an increasing percentage of patients tracheostomized using a percutaneous technique. So there is evidence not only to increase comfort compared to the other option for airway management, that would be orotracheal tube, with that is increased comfort and less sedative, less use of sedatives. That is a traditional benefit of tracheostomy, including most earlier indications. And there is from the 5 years ago, evidence not only to reduce weaning from the ventilator, but also reducing time on full ventilatory support, mainly because it reduces pulmonary and neurological complications. Most important of them are pneumonia and delirium, including long-term reduction in neurological impairment, not only talking about post-traumatic stress, but also other more severe neurological impairment. So there is, we can expect an increased number of eligible patients for tracheostomy because there is an epidemiological trend toward more severe, more aged patients, more frailty patients that will probably need a tracheostomy. Currently, it's worldwide, it's expected 10% from all mechanically ventilated patients. So as the previous lecture talked about some specific indications in the pediatric population, for adult patients, we have four most important indications. First could be severe reversible neurological impairment and airway compromise. This can be joined together because the cannulation pathway strictly depends on the reversibility and recuperation of this initial injury indicating the tracheostomy. But these two patients included in these two indications traditionally are easier to wean from the ventilator, and the most complicated point here in the pathway is to decide when to liberate from the artificial airway. And the other point are patients tracheostomized for prolonged need for full respiratory support and difficult to wean patients. The first group of patients that is full prolonged respiratory support traditionally has been defined at 21 days, but changing the timing for tracheostomy to a more earlier point, we can now talk about 10 to 14 days from the beginning of the mechanical ventilator. And in the second group of patients, those difficult to wean. Difficult to wean is currently defined that patients needing more than 7 days aiming to extubate and liberate from the ventilator. So now these patients, the timing of tracheostomy, in my opinion, clearly modifies the pathway and the how they are decannulated and more easily or more difficulty. So the earlier the tracheostomy, the less time to decannulate, to wean from the ventilator, and the more easier to obtain that outcome. So next slide. So obviously, and this is quite different from the previous lecture, in the acute care setting, and I'm talking about the point of view of intensive care, that is where most of these adult tracheostomies are performed. As soon as possible, the patient can be decannulated, then the better you decannulate it. So for non-permanent tracheostomies, the best point to decannulate is before the ICU discharge, and this is clearly better than after. And it can depend on the type of the hospital and healthcare setting. But the most important reason for this is that high risk patients not decannulated before ICU discharge are at higher risk for airway-related complications, just not step down, but conventional wards, and that can even compromise survival. Another point is that, in my opinion, preferably this protocol, this pathway to decannulate, it should be preferably performed in a high dependency unit or a step down unit. This is, I know it is highly variable according to the type of the healthcare system. It's quite different from the US compared to Europe. But in Europe, is increasingly performed inside the ICU, the intensive care setting. So an important point here is that if you do not decannulate before ICU discharge, there is an increased risk for permanent tracheal, mainly because performing decannulation inside the ICU, you have a high monitoring setting. So many decannulations can be difficult to decide. And there are many patients who have the debatable point of timing for decannulation. So if you have the safety to a rapid response in case of patients failing decannulation, you can you're more prone to take a policy like just do it, and then in case the patient fails, there's a rapid reversibility of the decannulation, so there's no consequences in most of them. And also it's really easier to monitor related difficulties to decannulate. We have endoscopy studies at the bedside in point of care whenever the patient needs, and whenever the clinical deterioration appears. So another point here is that the intensive treatment to accelerate and facilitate decannulation can be supplied in the ICU. So there is a team, including a team respiratory rehabilitation support, a specific intensive care physician, and these graphics are from Chicago, where an important study published more than 10 years ago that said that specifically trained intensive care physicians accelerate and detect patients easily to decannulate. It's easier to perform aggressive weaning protocols. On the next slide. So what the patient needs to be decannulated, well, I have to attend the most important clinical priority, those with an ability to keep very clear. So you need consciousness of or collaboration. It's better, but not always mandatory. As in Europe, at least, it's easier to move to a cerebral damage center patients decannulated, or dependency from the ventilator. And we should discuss about definition of liberation from the ventilator. It's not it's that long from the previous lecture. Or inability to deal with respiratory secretion. And here's the main concern is to define adequate cough, or just be a pragmatic approach and attend the needs to aspiration. In case of airway patency problems, most protocols include endoscopy technique to confirm and just to screen any airway patency problem, but we usually perform just as a clinical screening, and endoscopy is just to confirm. And another point is the risk for aspiration. Is really important to separate a risk for massive aspiration compared to micro. That's the micro aspiration are those more prone to produce pneumonia or any respiratory infection, and massive are more limited in the time of the evolution of these patients and easily preventable with emptying the stomach. In my opinion, swallowing is not that important to decide the point when we decannulate our patients. And an important point is you do not have to win a patient and then try to diagnose and manage all these factors limiting the decannulation. You should better manage all together.
Yeah.
So next slide. I don't know. Any other one? So maybe this can be the light for panel discussion. And I think I'm out of time.
Okay. Well, yeah. And so do you want to? You can have finish up this slide. Go ahead, Dr. Hernandez.
Okay. So we can apply the ICU easily. Some facilitators. For example, humidify. There is no direct evidence to humidify tracheostomized patients disconnected from the ventilator, but probably no one analyzed patients not ventilated, but receiving medical gases, that is 4 Celsius degrees and 0% humidity. We also can humanize the environment of the patient, at least facilitate speech. We are not prone to use capping trials for a long time, but we usually perform short-term capping trials to facilitate the speech, and that could be included as the neck rehabilitation. Here in the ICU also can intensify rehabilitation therapy. We call it triple therapy, that is respiratory, including inspiratory and exhalation muscles training twice a day. This is currently under analysis in a trial. At least upper way and torso balance should be included in this time of the recovery of these patients. And cough assist devices can easily help this part of the rehabilitation. Importantly, increase the effective airway diameter, and it is really important to choose the best material and cannulas that we put in our patients. And there are some specific diseases growing relevance in the clinical arena. For example, malaria, that the longer the airway remains pressurized, the higher the risk for some loss of this rated cartilage structure supporting the bronchus and trachea. Next slide, please.
Yeah, I might. Yeah, I'll bring. Yeah, we might come to some of these in the panel. There's a lot of those different elements that you covered in regards to the journey, but decisions along the way as well. And going back to that original point of why has the tracheostomy been put in, and looking at that, because that's not the same for all patients and families. And really I wanted to move that conversation into looking at working with families as partners in care. I wanted to hand over to you first, Laura, in terms of, how do we really have these conversations and collaborative conversations, and talking about the importance of what decannulation means and the steps. We've heard about, that it's really a journey. Can you give us some of your insights and experiences?
Yeah, I'm very happy to. And I'll be picking up on a lot of what Dr. Jimenez-Martinez said and Dr. Amin said as well, in the adult and pediatric populations respectively. So you'll see some of it woven through. Just to give the background, I'm an adult nurse practitioner, and I work with those prolonged vented patients who don't get decannulated in the ICU, and they end up in a high dependency specialized setting. And so we have them at that point. And we also work in the context of a trach hospital that has an adult trach team. And so there's this sort of multi-professional group that manages not only the insertion and decannulation, but some of the conversations. And so as a nurse practitioner, I work with this team to have and handle some of these relationships. And so again, just as my colleagues mentioned before, when we think about these conversations, really important, we think about, why are we having these conversations? Is it for consent? Is it to educate? Is it to, just make some decisions based on best evidence and goals of care? And so I think about it in terms of the context that we're in is usually quite a different context for people. My context is people who have been in hospital for a long time, so who have been in ICU particularly for a long time, weeks if not months. We work in large teams, multi-professional teams, who sometimes use different terminology or have different approaches to decision making. Also, we touched on this idea of tenuous shared understanding, and this has to do with medical terminology amongst ourselves, and also in terms of how patients understand certain words. And, really love that you mentioned this humanizing and communication issue, is that when our patients or, patients are talking to us and asking questions, sometimes they're doing it without a voice. And so they'll be mouthing words, potentially, that are different than we would use for certain parts of the trach and the decannulation process. So just as an example, a patient told me after they were decannulated and doing an interview with me on communication, that he was trying to use the word vacuum, and he was mouthing the word vacuum. And this was to navigate a conversation about the need for ongoing suctioning. And so you can see where there's breakdown there. So thinking about that in the background, this idea of shared decision-making is extra complicated when somebody's coming out of ICU and they're just sort of waking, they're maybe coming out of delirium, and the family member or the person who is playing the role of SDM is now sharing decision with that person again. So it can be complicated. And then in terms of conversation factors, just to say, both my colleagues just mentioned a wonderful list of things that come up into it: the need for the trach, the pathway, the implications, what happens if we fail, right, quote unquote fail, pros and cons, and then navigating the disagreements and some of the risk mitigation. And I'll just say, overall, really the need for more than one conversation and really providing some opportunity for patients and families to process the information and ask their questions. Documentation that is standardized so that we're all speaking the same language, and really not underestimating, the transparency about the process and the transparency about the uncertainty about some of the outcomes as we move along the pathway. And with that, I'll pass back to Amy to introduce Stacy, who I know both as a colleague and the family care partner of one of my previous patients. So I'll leave it there. Thank you.
Thank you so much, Laura, for touching on really salient points for us to consider. And yeah, I'd like to introduce Stacy to really give us some insight into your personal experiences and needs as a family member in that process of decannulation. Can you tell us a little bit about
Absolutely. Thank you for having me. I'm here today speaking as a family member who has lived experiences with tracheotomy and decannulation with my father. In June of 2021, my father was hospitalized in the ICU. He was there for a long stay with aspiration pneumonia. Despite many efforts in the ICU, we were unable to get him off of the ventilator, and I had to face the very difficult decision to have him trached. It wasn't a straightforward path. During this weaning process, we faced many setbacks along that way, where I was very uncertain if decannulation would ever be possible and if he was going to live on a ventilator. But little by little, there were little slow steps in progression. And then in February of 28th, 2022, we were finally able to successfully decannulate him, and we did remove the trach. It was a very long and about 15-month journey of hospitalization, but today I'm very proud to say that just last week we celebrated his 81st birthday at home, and he is on oxygen, but at least he's surrounded by family. So I'm honored to share this story and to help others better understand the real, kind of human side as a family member and the journey I kind of experienced with that. When you're dealing with family members, dealing with family members who have other members of the family that are trached, you're not just witnessing a medical journey with them. It's an emotional marathon is what I call it, because there are a lot of anxieties and experiences that come with that. And the decannulation process itself brought a lot of anxieties with that with me. So I'm just going to discuss kind of some coping strategies and some anxieties I had around that, which I think were important to share.
Yeah,
A lot of the there's a lot of the fears I had, particularly were a lot of the, did I do the right decisions in having him trached? Is this permanent? Will I ever hear his voice again? Because that was something that I know that I grappled with for a very long time. And just, the future was a big question mark for me and our family. The fear of hopelessness, feeling that, I was, in a very powerless position where I couldn't help speed up his healing process, or there's nothing I could do in that. And that came with a lot of guilt as well. Also to mention the physical and emotional exhaustion. I was in the hospital every single day. I was there in the evenings and the weekends. It had interrupted sleeps, having anxiety of, is the phone going to ring in the middle of the night because something happened? So your family dynamic, your family life really shifts when you're dealing with a family member who's trached and becoming decannulated. Some of the coping strategies that really helped for me that I think were very important was ask a lot of questions. asking questions, seeking, if there's something in language that doesn't make sense and they're using a lot of medical terminology that you don't understand, asking the care team to, put it in plain language that you understand. And then just be familiar, kind of ask a lot of the questions around decannulation. What does that look like? What's the process? What are the stages that I'm going to need to be familiar with? And then building the relationship with the care team. I feel like having someone you can approach, that you can ask questions to. For me, that was Laura. I turned to her quite often with that and questions, and it was key for me in my coping as a family member. Also, a lot of self-care. I feel that when you're dealing with someone very close to you that's critically ill and dealing with trachs and decannulation, you often feel guilty when you want to do something for yourself. So it's not being selfish. You do need the time, go for a walk, do things that you still enjoy to do. And it's about um, you know, celebrating the small wins. I feel like for me, it was, he's off of the ventilator for an hour. That was a win for me. There were fewer secretions today. That was a win for me. I feel like the small wins were big wins for me. And those were big steps that I feel like maybe other care partners didn't think that they were big monumental moments. But for me as a family member, they were large. And it just kept me looking out for hope, and I had hope in that. So, um, and I also think, be honest with yourself. It's okay to cry in these moments. It's okay to feel frustrated in the moments. It's okay not to be okay. And so processing your feelings, whether that's journaling or talking to someone or seeking some counseling, it helped me kind of prevent the emotional overload and feeling getting burnt out. And lastly, these strategies didn't erase my journey or the challenges that I faced, but they definitely helped ground me during that process. It was one of the most difficult emotionally things I've had to experience thus far. And so it really helped kind of ground me and figure out what helped for me with coping. As I share this, I want to offer people strength that are in this and other family members who might be listening. And for the care professionals, I just wanted to really illustrate that the way that we support families through these journeys and moments are very everlasting imprints. And so just wanted to share all that. And thanks again for everybody.
Thank you so much, Stacey. Wonderful reflections. Thank you for sharing such personal reflections, but a lot of learning and insight in terms of, what decannulation is and stepping back and considering everything that we need to do, and really checking in with families about along the way and afterwards as well. Thank you so much. And I mean, you reflected on your personal journey, and we've heard from all the panelists how journeys can be different. So in terms of the processes that leads somebody to having their tracheostomy decannulated, I wanted to touch a little bit on this and really invite Dr. Makimoski to talk about this. So as we're moving towards decannulation, sometimes there are specific considerations needed. Could you just tell us a little bit about, what you've had to navigate or some specific navigations required?
Yeah, thanks, Amy. And thank you again, Stacey. I think that, hearing, whether it's from a patient or a caregiver, anyone who can communicate it, I think that, hearing kind of what that story is reminds us all of, those of us who are more on the clinical side and the caretaking side, really reminds us why we do this. And it's helpful for us to hear that all the time. And so thank you for caring for your father in the way that you did. I would hope that all my patients can have someone that's caring for them as much as you were. From a pathways perspective, we've talked about kind of the standard thing, and I think that Dr. Hernandez-Martinez and Dr. Amin have both emphasized kind of the most important thing is determining have you corrected the underlying issue that the tracheostomy was put there to solve, and that can be something like a chronic respiratory issue, in which case then we have those discussions about can we decannulate to some kind of other respiratory support. Or certainly, Jody brought up as one of the questions in adults, the bilateral vocal cord paralysis. It's a physiologic problem with anatomic obstruction. In children, we deal with a lot of anatomic obstructions, a lot of blockage, a lot of small airway. It can be some severe sleep apnea that's contributing to it afterwards. But one of the important considerations is, even for those patients who have a physiologic reason, as some kind of lung function source as the reason for their tracheostomy being put in, there can be physical and anatomic barriers to decannulation. And for patients who have anatomic indications for surgery, there can be physiological or respiratory barriers to getting them weaned from any kind of support that they might need. And that's really where that kind of multidisciplinary approach is there, talking to other people, talking to the pulmonologist, talking to the otolaryngologist, talking to a thoracic surgeon, talking to a pediatric surgeon if there's something from in a child with tracheomalacia, and there may be some other options there, but really exploring those options and looking into it. Certainly it would be horribly irresponsible of me with everyone's time to try to explain every single thing that we could do surgically or respiratory to help out with these alternative pathways. But it is a group discussion, and oftentimes, pulmonologists on the team and myself will spend a lot of time looking at a bronchoscopy, a sleep study, an occluded trach that we're doing an active bronchoscopy while watching at respirations to try and figure out for these patients who do fall off of that pathway, what does it look like? What does their path forward look like? What is their path to success? For some of them, that looks like keeping the trach in for one reason or another. For some of them, that looks like an open airway reconstruction. For some of them, that looks like a leap of faith a little bit with the families, and with them saying, look, we think that we want to try something like a fenestration. But it's really that evaluation that takes place. And it's getting that expertise. There's so many different places. The airway is such a dynamic and important part that having a pulmonologist, having respiratory therapists, having otolaryngologists, having someone who has the experience, or being willing to call a friend to get someone else's opinion on it is always valuable, because there are many things from deviations from the pathway, while not the standard, should be evaluated more critically, and you got to make sure you have the right team in place for that.
Yeah, I love that. Your quote about being willing to call a friend and having that discussion and considering all aspects, and really highlighting, what does success mean? It doesn't mean the same for everyone and in every situation. So thank you so much for those insights. And just briefly also sort of touching on post-decannulation as well. So there might be some ongoing considerations post-decannulation that Dr. Amin also sort of highlighted earlier in your talk about that care required post-decannulation for children and families and adults. So just I'm mindful of the time, I wanted to do, while I have all of this esteemed panel here, to do a quick whip around. If you could give one key point for navigating decannulation success. So I'd like to just end by going around giving a key point for decannulation success. So we'll start off with Laura first.
I'll just say ensuring that you understand what the patient and family understand for the process and goals of care. Obviously, really understand what they value in terms of the limitations of keeping the trach in or taking it out in the process.
Thank you. Dr. Amin.
You say that it's a team sport. You need to have your team together to cover different things, because there's something that your ENT colleague is going to think of that you would have never thought of. Sometimes your RT is going to think of something. Sometimes your SLP is going to think about something, and sometimes the patient or their caregiver, brings something up that again is there. So it's really important to have the conversation initially to map out what needs to be done, but to also continue to have these conversations if things are deviating.
Thank you. Dr. Makimoski.
Well, Dr. Amin kind of took what I was going to say, but I would say, the quote that we hear a lot is make things as simple as possible, but not any simpler. And I think that's the thing, that there are protocols, there are pathways in place, and follow those. That this, if you have a patient who, move them down that pathway, but then don't make it don't make it too simple, right? If they're not following that and their pathway, what they view as success is decannulation, and they want to get there, and something along the pathway is not moving in the right direction, you have to get a little creative. And sometimes that requires, that's where the team comes in. Like Dr. Amin said, sometimes your pulmonologist is going to think of something that I would never have come up with. The respiratory therapist has an idea that they heard about. The patient comes up with something. And it's all kind of navigating that and making sure that you're all working towards whatever goal the patient and their family thinks of as success.
Thank you. Dr. Hernandez Martinez.
So probably whatever the final outcome is, we should integrate the family and make all the process more human, so it's less disgusting and frightening for all the persons involved.
Thank you. We'll go to Stacey and then we'll finish up with Erin.
I would say for as a family member is celebrate the small wins and just not to give up hope. If things get challenging, just celebrate all the small wins and the step forward.
Thank you. And Erin.
I would say that it needs to be a bespoke and tailored approach to every single patient. I think there are pathways, there are protocols, but at the end of the day, use the specialist team that you have available to you and do what is clinically indicated at the time, and that can be different from one patient to the next.
Thank you. And thank you so much. Just that really individual and patient-centered care. Vinciya, would you like to add in with your tip, please?
Sure. I would say that it's a process and not an event. And so decannulation needs to be planned well, staged and assessed, and not done hastily. So if you're unsure about readiness, it's better to wait and reassess because premature decannulation is riskier than a short delay.
Yeah, thank you. And also wanting to call out Dr. Brenner. Any tip that you would like to give over as well?
Sure. Well, thanks, Amy. I think my main insight from all this would be just how affirming it is to see both the discussion about how we advance the science of improving care and how we also advance the humanity and patient-centeredness, and that those two really are closely intertwined and mutually reinforcing. And we've really done a pretty remarkable job of capturing both the set of panelists, but also an audience that embodies all those things. And it was really kind of exciting to see just so many different geographies represented and so much engagement. So, and thank you, Amy, for just a phenomenal webinar. It's really a privilege to be of service to the organization and to see the great work that all of you are doing.
Thank you. Thank you so much. We sort of done a lot of the Q&A throughout and really moving on to our final messages to close up the webinar. So I'll just sort of mention the next webinar before I hand over to Dr. Pandian to close it off. But our next webinar is the 7th of August, and it will be on transition across care settings. So just over to Dr. Pandian for our final word before we close up.
No, thank you so much. Actually, Dr. Brenner did a great job of summarizing and really thanking you for this wonderful session. And a big thank you to all the panelists for the time that you've taken coming for all the pre-planning sessions and really thinking through how we can make this valuable for our audience. And a big thank you to all our participants who joined in. If you have questions, please do email admin@globaltrach.org. We'll be happy to respond to you since we are short on time. I did see that someone had a question, so please do email us. One other plug that I want to put in is that our 9th International Tracheostomy Symposium is going to be held on October 23rd and 24th in Chicago. So please save the dates, and we hope to see all of you in person there so we can meet in person and share all the amazing work we're doing, and also learn from our colleagues, our individuals who have a tracheostomy or had a tracheostomy and their caregivers, because I think we tend to learn a lot from them. We've done so many webinars, so many ITS, but that's the time when we speak to them and listen from their lived experience, we learn more, and we can improve the quality of care that we provide. So thank you all again, and great seeing you.
I'll just add that this upcoming meeting that we have in Chicago, we're really excited about it. It's truly a beautiful venue, a new facility. It's right in the heart of the city in Hyde Park, and obviously we come there for the for the sense of community, the science, and the conference. But it's really just an incredible city, and I hope that some of you will find it worth the trip.
Thank you. See you next time, everyone.